to start this conversation, most of us have been involved in advanced care planning. We have been doing this, the coalition, since 2012. We've been meeting, we've been working at ways to do education and to promote education about the advanced care directives, about the POLST. And now we have an article that comes out, an opinion that comes out in October that says, what? This is a waste of our time. So we decided that it'd be worth having a conversation and put out opinions about what this is about and hear what you have to say. Now, I have spent a lot of time doing advanced care planning, and sometimes I find it effective and sometimes I don't. And I'm interested to hear what other people think and why this has become a conversation. So if you will unmute yourself when you have something to say. So, and the interesting, and I want to say this up front, Diana is having trouble with her audio. So Diana, I need you to be part of this conversation, so you may need to put it in chat. You have about a valuable voice. So Carla, were you going to share?
Yeah, thank you. This struck all of us. And at first I was, interestingly, I was like upset. I was like, what? How can anyone say that what we're all trying to do is not working, and then I think that it was a really good article because it really made me think about what's working, what's not working, how we can improve it, and how dedicated are we really at doing this, And so after going through a full circle of reading this article several times, I came to the realization that there are substantial gaps in reaching our patients and informing them and counseling them on advanced care planning, significant gaps. And it really is highlighted by the way it's supposed to work, and we know it doesn't work. When you have a whole community of providers that are responsible for delivering advanced care planning, and they all have their different values, they all have their different opinions, that's too many cooks in the kitchen, one. Two, it's confusing for the people that actually need guidance and need counseling. And I think that it's a lot of the things that at first the author, I was like, no, not right. But a lot of the things the author said were true. I mean, the steps for successful advanced care planning, those 8 steps that were discussed. Yeah, that sounds like reasonable 8 steps. But I think where the authors, I don't want to say maybe mischaracterize, is one, I think that they mischaracterize some of the studies, and two, they posit a solution that I think puts us in the same place, because at the end of the day, advanced care planning is about educating both patients, the people that need the advanced care planning, as well as the people that are delivering the conversation. So it's one of those things, if we're all on the same page and we're all being, truly in that consult perspective and trying to eliminate our bias and our opinions on things, then ACP, that's the purpose of ACP. But I think that whether it's the author's posited solution or the current approach, it still comes down to educating our providers about ACP, and then removing a lot of this bias that's occurring in these conversations. The last thing I want to say is that, and Andrea, you sent that podcast, which was fascinating. And again, they have kind of a middle of ground kind of feel to it. They say, yeah, there are issues. But one of the problems with the studies is that how do you measure anything in advanced care planning when you have every cook in the kitchen? Do you measure every cook in the kitchen's input and their efficacy in delivering it? Well, you can't do that. Or maybe you can. Maybe there's a different way. Maybe it's a platform that kind of monitors everyone's input into advanced care planning, or maybe it's something some other way. But we have to acknowledge that if we're going to have our whole healthcare system provide advanced care planning along the spectrum of care, then we need to acknowledge that we need to figure out how to address these biases and or just coach up everyone in healthcare to be more true to it, to advanced care planning, is my opinion.
So Carlo, I want to ask your definition of what those biases are. What can you kind of pinpoint them?
Carlo, before you answer that, I just wanted to confirm that everybody on the chat kind of knows or remembers the salient points of the article and the responses thereof.
Correct.
Before we jump deep into the discussion, is any cogent one of you can quickly summarize the key takeaways from the article as well as the responses that you've looked at? And Andrea, Carlo, Diana, anyone, Terry, feel free.
Well, okay, so that's why I was asking about those biases, trying to pinpoint that. So, and the biases of the conversation, that the decision-making is not happening, it's happening at the bedside instead of happening as the time goes along, that it's about a paper document. It's not about the conversations. It just makes me think again and again, they're missing the point in the conversation. That's where I come back to. And I really would like to put Andrea's comments out there, but I don't want, it's such a good conclusion that I hate putting it out at the beginning. I'm just being honest. Her comments that I received were just amazing. So anybody else?
I mean, I could kind of stab a kind of summary. I mean, they first talk about these 8 steps to a successful advanced care planning. And it involves, you know, identifying patients' goals and values, and having a clinician able to elicit those values and preferences, then being able to document them, being able to discuss this with the patient and or the surrogate decision maker, and making sure that if a surrogate is involved, that their judgment is actually kind of reflective of what the patient prefers in terms of treatment. And then to rely that on the notion that clinicians will look at these documents when the time is right, let's say in emergencies, and then for clinicians to turn around and then honor those wishes that are documented, and then have health systems commit resources to maintain this ACP environment, so to speak. And those all sound like the right steps that need to occur for ACP to be successful. Hidden in those 8 steps is the notion that education is important for clinicians so that they are able to conduct successful and effective ACP conversations. The authors then turn to say that ACP basically has failed. The failures stem from several things. It stems from focusing, as Terry said, focusing on completing the document, relying on a document that may not be relevant at the point when there is an emergency, and then failing to have that up-to-date conversation is another component. And then really patients not having, you know, talking about the hypotheticals in a document that have no real applicability when an emergency actually occurs. So that's two sides of the same coin, is that, are we having conversations with our patients that are relevant to them at the moment they need the conversations? And is a document as an effective substitute for that some of the time, if not all the time? Well, we all know it's not an effective substitute all the time, because clinical conditions change. And once that condition has changed, another conversation that needs to occur. That is the crux of ACP and PULSE, is that it needs to be updated. But I think that our health system has just said, let's just fill out the form, and you know, we don't really have to worry about a new form. Let's just, you know, if they have it, they have it. If they don't, they don't. So healthcare systems don't really emphasize the conversation. They emphasize the document, if you want to call it that, you know, emphasize. And so that is another failure, is for our health system actually effectively supporting ACP generally. Is that a fair summary of the article?
It is, and I actually posted in the chat the summaries that you just defined. You mentioned the healthcare system having the conversations, you know, not looking at the document itself, but I think that also through our own agencies, we have been missing the point also. It's been all about the document and not about the conversations. As I teach advanced care planning, I'm always going back, and I feel like I'm this recorder that says it's all about the conversations. It's, you know, the piece of paper is not as important as the conversation with your loved ones, your friends, your physicians, and it's not a once and done, right? So that is how this message has to be balanced out. And that's my opinion. And I think that's part of the opinion of those who really understand advanced care planning. Now, anybody else have an opinion along this line? And look at Dr. Jazz Corbramani and you, Carlo, but also Diana, in dealing in the hospital systems with this, and how is that working out with the documents and the other pictures behind the scene? Jazz, do you have anything to say on this?
I think that if there is a document, it serves as a good springboard to start a conversation. And if you don't have a document, you find another springboard. But something that was said in the chat was preferences are fluid, because it's really hard when I'm creating an advanced care planning document to know exactly which intervention I might need in the future. And there is no way to prepare everybody for every clinical scenario. So I don't know if that answers your question.
Well, you know what, that's interesting, because last week when I did wish 2 of the 5 wishes, which is very specific on life support systems, and I mean, I went into the descriptions of all of the life support, and somebody asked the question, so how can you tell all of the scenarios that could happen? And it's impossible. It's totally impossible. You can't say all the scenarios, because it could be sudden, it could be a stroke, it could be chronic. So that all needs to be part of the conversation. And the other part of that is, and I liked what the Jerry Powell had, it comes back to function. What is the function, your frailty in your life? You know, where are you headed? Again, not the once and done. And I don't mean to be taking the whole platform. I'd love to hear from other people.
Yeah, Terry, I just want to quickly mention that what I loved about that podcast was the idea that the people there, the experts there were saying, yes, there is a failure, but the failure is due to many things. One, it's again the too many cooks in the kitchen concept, and patients that are hearing different things from different people, and then they don't know how to make decisions once they hear that. The other thing, and kind of like the upshot of that is that, you know, and this happens to me, and I want to show of hands to see if you guys have all experienced it. There are people that change their minds when there's an emergency. They're like, wait a second, I am not ready. I need help. Okay. It happens every time someone comes into the ambulance, say from a skilled nursing facility or from hospice, and they reverse hospice. And here's the interesting thing. Before this article, I thought that this was a failure in ACP, but is it? It's not. It's just the change in condition. Did we fail? Now, are all these articles saying that ACP is failing because that happens? Because if that's what they're saying, ACP is not a failure. It's just part of the process. So right. How many of us have seen this? People change their minds all the time, and that should be okay. It has to be okay. You know, but we don't see it that way in ACP. We don't see it that way, you know?
So that leads to the comment that Diana put in the chat, and I'm hoping people are reading the chat, but the not treat, Diana said, hang on a second, I gotta be able to get to the whole thing. There is a continued thought that DNR means do not treat, and if a pulse is present, then it can be confusing. When there is an acute event, the conversation needs to be a continued review function and possible options. Right. So, and that's exactly what Diana had to say, is that it's not, you know, you've got to look, you have to have the conversation. And then it brings us back in, and maybe I'm throwing this off, but it brings us back to that conversation of the family. They've all made this decision. The daughter is there who's trying to decide for dad. And then the physician walks in and says, if we do this, and it can feel like a monkey wrench has been thrown into the mix, but sometimes it's not a monkey wrench. Maybe this is a conversation, and very possibly a conversation that needs to be had for what is that it really matters to that person. And maybe that suggested feeding tube is a positive thing. Maybe it's not. So those are sometimes part of the conversation that we feel like the advanced care planning is not working, because now we're talking about a G tube and mom never really wanted to have that feeding tube put in. So any comments about that part? It's the physician that throws the boomerang in sometimes.
Well, I do want to say this is why I'm such a huge fan of the California Coalition and the Pulse document, because if you, every line item there carries so much weight. The Pulse specifically says reevaluate, reassess continually with every change in condition, because as Carlos said, people change their mind. And then as to what you brought up, Terry, the physician comes in and offers something, and this is why it is the quality of the conversation. And there's some doctors that go in the room and our team is like, oh my God, no, please go with him or her. We don't know what they're going to say to upset the apple cart.
Yeah. Well, and or the family member that comes from across, that didn't have the conversation with the family, and now they're there going, why is this happening? I mean, I had a stepson that did that. So why aren't we sending this hospice patient to the ER? He should be going to the ER. So it's not always as easy as that this research or this opinion made it look like. So Lynette, can you say what you were talking about in your chat? Would you like to talk about that?
Sure. I just see a lot of personnel in the medical facilities, whether it be SNF or acute, that if someone's a DNR, they think that the person doesn't want anything at all. And I really feel like that conversation among medical providers needs to be talked about a lot more. So I appreciated Diana's comment on that, because I do think it needs to be discussed a lot more among medical providers.
Thank you. I agreed. Leah, I'm not sure if you're there. I'm hoping you are, but I would like to hear a perspective from the world of the Alzheimer's organization and how this looks like because somebody should be having a conversation at least at the beginning of their diagnosis, and that could be changing. The whole picture changes as they're growing through this diagnosis.
Yeah, absolutely. We'd encourage people to have these conversations as early as possible, because obviously at some point fairly soon, the patient with Alzheimer's disease is not going to be able to have these conversations. And, there's a lot of decisions that need to be made along the way with Alzheimer's disease, but the decision for life-saving interventions is a huge one. We always encourage people to use the forms that are available, but we're also trying to develop our own that are really specific to dementia and what sorts of symptoms are kind of beyond the pale for the family. What's your marks for taking the next step, for placing the person, for putting them on hospice and things like that.
So it's an important part of that, something that it is that chronic disease, and the continuing conversation, and encourage them to have the conversation with their loved ones, all the people in their lives, and their care providers. Carla, did you?
Yeah, that's I wanted to comment on that. I think that documentation that's more kind of specific to patients with dementia. I'd be interested in learning more about what you're hoping to achieve. If people here are not fully aware, we are launching an electronic pulse registry in Ventura County. We're working with the Ventura County EMS and the state EMS. EMSA is the caretaker for electronic pulse, and we're working with the California Coalition, and Judy Thomas is in support of what we're doing here in Ventura County. we have a platform that allows both an electronic post submission as well as uploading of paper forms. So if there is a form that you would like to submit that would be available to people that have dementia, I'd be interested in speaking with you more, and we could upload it into the registry for people with dementia to use. Would that be something that would be helpful for you?
Absolutely. And if Diana can share the roadmap that she has of realistic expectations, that'd be perfect. What we're thinking is just, you know, something really informal that, as Terry was saying, can just help families to guide the conversation, because we think it's hugely important to have these conversations and that people should be talking about this. I grew up with two ICU nurses as parents, so I've had these conversations with them many, many times, but my husband has never talked to his parents about what they would like. It's you know, it's something that's really, really important to have conversations and to understand what somebody would want, not just in a specific situation, but in the type of circumstance that they might face.
Right. Martha posted in the chat dementiadirective.org in case you're interested. That's interesting. Also and I wasn't ready to go to the electronic post. It's good to bring it up though, but there is an area for having documentation, continuing documentation between the people who have had conversations on the electronic poll site. And as we started this conversation related to the opinions on the studies, we're hoping to link that to official scientific study. And Carlo and I will be meeting tomorrow with somebody who's already involved in studying advanced care planning. Correct, Carlo?
Yeah, so this is a bit of exciting news. Susan Hickman is the leading researcher in POLST in the country. And she's interested in finding out what we're doing. And when we had spoken with Judy Thomas, she hooked us up with Dr. Hickman. And in particular, there's some interest in the idea of having a multi-center study, both in Ventura County and possibly beyond Ventura County, to discuss the effectiveness of electronic POLST implementation. And the power of this study is really relies on several things. One, having multiple centers deploying it, which is where we're planning on doing through the support of the Ventura County EMS. And then two is the idea that the platform is available not only to people that need to have the form for themselves, but family members, surrogates, the whole physician teams. So that whole idea about too many cooks in the kitchen and confusion is something I really want to address through the electronic POLST, right? Because if everyone is kind of engaged in the same platform, then all these changes in condition, all these changes in their minds, and the updates can be kind of facilitated by a POLST registry. So I think that this criticism about ACP actually kind of prompts the need for electronic POLST. So that's what we're going to be talking to Dr. Hickman about. I think it's tomorrow, is it?
It is.
It's tomorrow. Yeah. So exciting stuff.
So you need somebody to manage your time and your calendar.
I look at my calendar in the morning and go, oh my gosh, I have a busy day. I don't even look at it.
Look at the rest of your calendar when you're scheduling. So
too scary.
It is. So
Terry, if I could
please,
just
Tim, I would like you. I was hoping you would speak to us.
So I'm an attorney. I do estate planning, and when clients come in, I tell them they need to do a healthcare directive, and I assist them in doing a healthcare directive. I also talk to them, and I've been talking to them for a number of years about a POLST, and I explain to them that one of the reasons why lawyers can't advise about POLST and why a physician has to sign on to the POLST is because lawyers are not competent to advise with respect to the issues raised in the POLST. But the reality of the situation is lawyers are not competent to advise on the issues raised in the healthcare directives either. I mean, actually, you know, I get to cheat a little when my clients want to have a deep conversation. I bring Katie in and she meets with them, but otherwise there's very little that I can offer in the process. And so you've got, for those who do estate planning, for some attorneys, they don't do the healthcare directive, or those that do, it's an afterthought, and they're like me, not competent to counsel anybody on the issues. And then even if I'm talking about the issues with clients, because some clients have had the experience with their family or others, the reality of the situation is that the clients are as ignorant as the attorneys. And until the healthcare professionals, I mean, I tell them, you got to take your healthcare directive, you give it to your doctor, have a conversation with your physician. It doesn't mean they do it. I tell them to talk to your doctor about a pulse, although I think from prior discussions, I think Terry with you part years ago that, not everybody should have a pulse in the opinion of a lot of people in the healthcare field until they're terminal or older. But those are conversations they should have. So one of the problems with advanced care planning, I suspect just inherently, is you have an ignorant person telling somebody who's equally ignorant to fill out a document that neither of them really understand. So it does sort of start behind the 8 ball, but eventually, hopefully, it's brought up to current thinking and discussions with competent people, such as other people on this call, who can counsel them. But one other thing I'll say, the American Bar Association has principles of advanced care planning, and one of them talks about it should be an ongoing conversation. And when you first prepare your healthcare directive, you should not be focused, if you haven't been diagnosed with any terminal conditions, you should not be focusing on specific diseases, but just generally what your views are. And so that inherently means, there's going to be change. And whatever you're drafting today, it's like any estate planning document. I've never seen somebody come in, if they've ignored their estate plan for 10 or 15 years, everybody's going to come in with a different view of their circumstances in life and their children and the factors. And it's even more the case, I think, with healthcare, because frankly, it's far more important than finances.
Thank you for your honesty and outreach there, because it's always a concern to me when I'm speaking about advanced care directives, and many people say, well, that's in my living will, that's in my trust. And so it's always a concern to me that they haven't really had a conversation, and that if that advanced directive is mixed into the trust and not as a separate document, then it speaks to what was talked about in the Jerry Powell, that it's hard to find, it's hard to know. So your openness and your frankness about doing that with your clients and ability, I really appreciate. I want to honor that. And saying that, there's 2 things I want to do. Jazz wanted to make 2 points, and then I want to go back to Denise, because I think she has a very important point to make also, and I would like her to talk about that.
Okay,
Yeah.
and thank you. Going back to what Ken was talking about, you mentioned the ignorant client and the attorney who may not have a lot of healthcare knowledge to discuss these issues. The push to move advanced care planning upstream has also resulted in moving it from the providers who are at the point of delivering these interventions and who understand that landscape. You move it upstream and you take it to the doctors in the offices. And we know now that healthcare has become even more siloed. So in the last 5, 10, 15 years, doctors in their offices are no longer going to the hospital, and they are no longer delivering those interventions. So they have really a diminished understanding of that landscape. So the push to move it upstream has moved it upstream to providers who don't really understand the landscape and aren't comfortable talking about it. So you're going from 2 ignorant entities to 4 now ignorant entities and adding to the confusion. So that's number 1. Point number 2 I'd like to make is, it's really valuable in the advanced care planning, advanced directive documents, when we ask people to say, what is important to me? What makes my life worth living? But one of the things that the document really needs to focus on is the concept of who gets to define burdensome. So an example, we had a patient who was completely bedbound, advanced dementia, and her son's taking care of her. He's a wonderful, devoted son, changing her diaper, putting formula into her feeding tube. And he says to us, my mom's not a burden. And it took me maybe a couple of years to think, oh my God, would she consider this a burden? She gets to define, she should have had the opportunity to define whether or not someday in the future, her son changing her diaper 5 times a day, would that be a burdensome life to her? Or is that a life she would accept? So advanced care documents and planning and conversations really do need to spend a little more time on understanding what would be burdensome, not just what would be beneficial. That's my second point.
Totally agree. And Lauren wanted to make a point that she was in agreement. Did you want me to speak for you? Would you like to speak?
No, thank you. I was just listening to everything the kid was saying, and being part of Nurse Corps and home health, we've experienced the same thing. It's just have this discussion when we're bringing new clients on board. And even when our registered nurses go out to admit these new clients, they don't feel comfortable having the discussion. The family member doesn't feel comfortable having the discussion. And so we just start off behind the 8 ball, just like he was saying.
Yeah, and it is. I find it interesting that I believe that all of our staff at Livingston, health nurses and caregivers and therapists all need to have continuing education on this. And it's something that I think is neglected. I think it's an important part of it, especially with our hospice nurses, right? And then I do want to show that Diana put in here about the pulse. The expectation of pulse is for clients that you would not be surprised if they died and a greater year or greater. I usually say around 2 years, and there's some inappropriate pulse done, but more are missed. Also, I'd like to say to that point that people with long-term disabilities, mentally disabled, sometimes the pulse is used in those circumstances because when say my son has disabled and he goes into the emergency room, and automatically an ER doctor and the nurses come and say, well, this is your opportunity to allow him to go. And that's not what that family member wants to hear, because that's not the decision they made. So sometimes a pulse is used as a life-sustaining factor, just what it's called, the physician orders for life-sustaining treatments. And so we don't need to jump to the conclusion that a pulse is there to allow a natural death or DNR. So that's the other part of that. And Jazz is adding, all healthcare providers should have training in ACP and palliative care now, and it needs to be continuous and it needs to be required. So I really do want to get to something that Denise said, and I think it is part of this factoring in the conversation. So Denise.
Good morning, Terry. Thank you. Personally, I had to deal with getting a pulse from my mother. And because I've watched Diana so many times speak to churches, people of color in my my own backyard, and she was a guest speaker, and a lot of those individuals didn't quite understand what it was about. She made it clear. However, more education, I think, would be on a regular basis every year to remind them, because when their child who goes through some kind of issue of some sort comes back home, doesn't know that that parent has made that decision, now they want to save the world. And you know, I have a sister who is extremely religious, and she argues about people being cremated versus being buried. And I have a brother, his opinion is, you know, mom wants to fight, mom wants to fight. My mother ended up having a heart attack, it was a massive heart attack, which was great. But I believe in my heart, if my mom would have been brought into the hospital, we would have had decisions that would have been very, very, there would have been a lot of controversy. There would have been a lot of infighting, because even though she had her wishes and we knew what her wishes were, and she told me 7 days before she had her heart attack, if my maker comes to get me, let me go. And I didn't understand why she said that. We were sitting here watching a fight, and she said that to me. And then I told my sister, who was in the next room, and she goes, what is she talking about? I said, she said, if her maker comes and gets her, let her go. And to me, she already had made up her mind. She was ready if something were to happen. We don't know how she was feeling, but that was something that will always stick with me. So I think about culture, because every culture is different. And I know in the culture that I live in, people don't want to talk about it. They're afraid if they talk about it, then it'll happen. And I think the approach to everyone is going to meet their maker one day is the approach. And then, you know, going from where that person is and making sure they include their family, even if their family is not there. And I think it was because my sister lived outside the area. She had one opinion, and I had a sister that lived in the area had an opinion. But I think everyone should be on board. I think making sure the family members, even if they can't be a part of that initial conversation, making sure they're a part of the conversation, that these are the decisions that were made. Even though her doctor explained it, I explained it, and the social worker explained it to her. She was okay with her decision, but those family members are the ones that would create more of a problem. I just wanted to add that.
Thank you. And I'm glad you referenced the culture, because it is not, it's not the same for every culture and how we approach it and how we discuss it. So you're talking about a Black culture, there's the Hispanic culture, there's the Filipinos. I mean, if we just look at our own Ventura County area, how many different cultures there are. And I will tell you, within the white culture, there are different cultures about it. It's, it's not we don't all fit into the same silo of the way we think we should. Jazz, would you like to speak to it? Oh, wait, hang on a second. Diana said that there is also the culture of long-term disability patients. Oh my gosh, yes. Yeah, a chronic illness. Each one has their own culture.
No, I don't really have a specific comment, just what I put in the chat when Denise was talking about culture and how her mom, something prompted her mom to say that to her. Maybe it was in the movie they were watching. So I find shows, movies, and pop culture a great way to engage loved ones, or a way to bring up the issue.
Sometimes it's very hard and it can be very painful, but well, often is. So that's a great way to do it. Did somebody else have a comment?
Yeah, I was just going to say, I put in the chat, I have family members that definitely have different opinions with regards to, people in my family that are older, and some have filled out polls, some haven't. And it's across the board, in my extended family. And but we have a chat, like a text group for all my aunts and all my uncles. And so whenever something happens, oh yeah, my aunt's doing this. And so we all kind of come together and talk about it. And it's that open communication, and everyone has their opinions. But I think that and I always steer them towards, well, yeah, but what would Auntie want? Like that's what we need to be asking that question. And so that reminder for family members that otherwise have differing opinions ends up helping them accept the fate that will occur at some point. So it helps their healing too. So I think that good communication among families is key, and maybe whatever it takes. I mean, whether it's watching movies together or just, having it's a text that that pops up. Oh, Auntie is now going to the hospital for this. And sometimes that just helps so that everyone can air it out and talk about it. So that's just my own personal experience.
Good. Anybody else? This has been an amazing conversation and I appreciate it. And
Sherry?
Yes.
Sorry, one of the points you made earlier in the chat was family members have difficulty sometimes applying substituted judgment. So when we say to them, like Carla just said, what would Auntie want? A lot of times they tell us, well, I don't know. We never talked about it.
Mm-hmm.
But, watching, one time she watched a movie and she said, I would never want that. That can be really helpful to bring in that aspect of substituted judgment.
It's absolutely true. And once you begin to edge in these conversations, they begin to recognize it. And my husband has said, did you hear that on the TV? That's what I don't want, right? So you have to begin somewhere to talk about this. And maybe it's just a little thing, but it could be a conversation of saying, I'm really uncomfortable with the idea of having a tube put down my nose. What do you mean about that? So conversation came up during a card game with my daughter and family at a Christmas that I really don't want CPR. And Tim looked at me like, what? You're young. And then I went into the conversation. Now I'm a nurse, right? I'm Frank. I teach about this, but I went into the conversation of how horrific that can be so that everybody could understand that. And speaking of that, in this conversation last week, I had a lady who is older, well-educated say, I had no idea that CPR was like that. So people really don't understand. She was really grateful that I described the horrors of CPR. And but people don't always understand. They see something on television, they hear about it being so successful, but they don't know the actual truths. So how do we begin those conversations? And as Denise said, it's talking with family. It's an ongoing conversation. That's what we started with this at. It's an ongoing conversation, and it's needed education for everybody. So did I miss something up here? I did want to, before we finish up, and I really do appreciate everybody's conversation, I'm posting in the chat what Andrea sent out, and I'm not sure everybody saw that, but I think it's valuable because of her takeaways. And her takeaways, and again, she says she's a neophyte at this. I don't think she's a neophyte at anything, but she is definitely not a neophyte in being able to extract information and communicate it well. So you are a major expert in that, and I honor that. So we have made some good progress with ACP over the past number of years, getting many folks to talk about end-of-life care, getting many folks to appoint a surrogate. However, that progress may not be able to be evaluated or be evaluated in a positive way with success criteria like less hospital days, something we didn't discuss. In reality, an end-of-life conversation is an iterative one and made among many of the people in the healthcare field touching the patient. It is hard to evaluate outcomes with so many moments of conversation and so many players in the mix, something we have discussed. Getting to the why behind choices, for example, in a pulse is important, especially when the physicians executing the pulse may be having conversation with a surrogate or family member that do not agree. People don't know what they don't know about how serious illness may impact them when they are healthy and making end-of-life choices. Advanced care planning does not take into account in the moment decision-making. A next step in advanced care planning may be to follow a process of serious illness communication, accessing illness understanding, function versus time-based prognosis, understanding patients' values and goals, and the medical provider expert making a recommendation based upon the first 3 steps.
So Terry, can I elaborate on that for a second?
Oh, please do. And I think this was amazing outcomes that we have talked about, and I think you should elaborate.
Yeah, one of the things that the Jerry Pell podcast really brought home to me was this whole concept of serious illness communication. And I know with the folks we deal with at Senior Concerns, there's a lot of serious illness communication going on. But one of the things they talked about is assessing what the patient understands about their illness, getting them to iterate to you their understanding, or even a family member or a surrogate, their understanding of the illness, because sometimes what happens is they know a small piece, but they don't know the big picture. And don't know what's coming. And so as a result, that makes it really hard for them to have conversations about advanced care planning. The second one is a function versus time-based prognosis. So the conversation sometimes goes, well, if someone has cancer, well, you may have between 6 months and a year to live, versus this is what's going to happen to you functionally. As things progress, you will no longer be able to walk. You will no longer be able to talk, whatever the situation is. I think that can help patients. It's a hard conversation to have, but it's an important one to have so that people can make their end-of-life choices. And understanding a patient's values and goals. For instance, there may be a value that it's nothing more important for an individual than to be able to spend time with their grandchild. And if that meant having a feeding tube, even though before they were definitely against having a feeding tube, but if that meant more time with the grandkids, then that may be something that's important to them, a value and a goal that supersedes that interest. And then the last is the medical provider who's the expert making a recommendation based upon knowing those 3 things: how the patient understands their illness, what functions are important to them as they move forward in their illness, understanding what their goals are, and then making a recommendation. The problem is that physicians rarely get the time to understand their patient well enough. I mean, sometimes when there's a longer term cancer diagnosis, there is that. But frankly, with a lot of the other chronic illnesses that we see, we don't have the, a physician doesn't have the luxury of understanding their patient to that depth. And as Carlos said earlier, and was part of this article or podcast, was that, an infinite amount of people are touching that patient, and I see often that if a palliative care or if a difficult conversation has to be had, the physician calls the palliative care team. And to some extent, that's good because they're most well-versed in having that conversation, but and in asking the right questions, but it keeps the physician out of the loop again in truly understanding their patient. So anyway, my last comment in all of this was that saying the basis of that whole article, is AC, is advanced care planning not worth it or useless or whatever the case may be, is like saying that, getting rid of first base in baseball because it's not a home run, when in actuality, you can't get to a home run unless you go through first base. So ACP is part of that getting a home run. And that's why it's critical in the outcome. And that's why we need to improve it, whether it's electronic polls, whether it's about, for instance, I love that Ken and Katie have teamed up because I think they are the best opportunity for an attorney to be able to provide his clients the kind of conversations and guidance and expert guidance that they can have. And I think if more attorneys partnered with more hospice agencies, for instance, I think that they could create a vehicle where they could have better conversations with their clients about end of life. So anyway, I'll leave it at that.
Thank you. Great. And remember, you're just a neophyte. I really wish when you wrote that synopsis, I thought that would make a great article in the Acorn or the Star. So just an idea.
Yeah, I was thinking that everything that y'all have said, I mean, Terry, your parting comments previously, and Andrea, what you've just said would be a great way to start kind of an editorial piece in response to the JAMA article. Just what you guys just said. It was fantastic. Perfect.
Yes.
Beautiful.
Perfect. Well, and it's also, by the way, Jazz is saying that they may have wrote that article just to energize us all. And there has been that moving around that idea that maybe they did that. But so speaking of energizing us, as this is beginning of a meeting and hoping to continue to meet and coming up with ideas to meet about, I'm hoping that you all will come back to our next general meeting. And I would like you to put on your calendar now, it would be April. Now I'm the one forgetting the date. Tuesday, was it Tuesday?
7th or something? I don't know. Why
7th, it was at 4:30 p.m. It's going to be in Carla Reyes's backyard. We are going to have an actual meet in person. And that date was in the newsletter. What was it? April 28th.
Yeah.
We will be meeting in Carla's backyard about 4:30. And we will be having a little bit of wine and hors d'oeuvres. And I will put out the ask even now, if you would like to be part of hosting that, we would appreciate that, since Ventura County Coalition for Compassionate Care does not have any funding except what you provide. We'd appreciate that. It would be a great opportunity to bring those you think would be interested in knowing more about advanced care planning, being involved in this coalition, and seeing the video in person of that we made 2 years ago and wanted to do an opening for, and didn't get to do it because COVID came along and shut all our doors, basically. So put that on your calendar, plan for it. And then also, if you had noticed that Carlos began to do a newsletter, I hope, did anybody see that come out? I need to see any possibilities of that. So thank you, Denise. I see that possibility of helping to host. I'd appreciate that. Carlo had the idea we were going to send out this message about this meeting, and then Carlo just turned it into a newsletter to begin. And I think that's a very possible good idea. And that may be something that we will be doing on a how often basis, Carlo?
I would think maybe 3-4 times a year, something
That's
like
what
that.
I'm thinking, a quarterly
Just
basis.
to update people on what we're doing. And, as we launch ePulse, I think there's going to be a lot of activity and energy in that. And so anyone that's really interested in helping with that, there's going to be lots of discussions, lots of things going on. So that's pretty exciting. If I could pitch my fundraiser event on April 9th, we're sending a medical mission to Nicaragua. We're going to be using a global telehealth platform to interact with US specialists and then conducting medical services in Nicaragua. So it's going to be the kind of the first that anyone's ever tried to do. So we're pretty excited about that. The gala event is going to be super fun. It's the Masquerade Gala. Okay. So if you haven't received an invite, then get me your email, or maybe I'll send it through the VCCCC MailChimp as well, so that everyone can get it. And if people don't have the VCCCC quarterly newsletters, contact us directly and I'll see what's going on. It could be in your spam or something like that, but I'll make sure that your email is in our list.
So speaking to that, because I wasn't sure everybody got that, I sent out again through the Ventura County Medical Association, through the Constant Contact, the invite, and Julie put it in the calendar. I will speak to her about doing it in a different way so that people do not have trouble. But if you could spread the message that we're here, we're going to meet, we're going to have conversations about advanced care planning and education. And to say that, we need your help to do it. This is not a Terry Carlo steering committee organization. This is an organization that in order for it to survive and to move on and to do the education, we need your help. So how do we do that? Conversation on that end? Commitment? Suggestions? Is this something we could do by committee on Zoom? If I send out an email looking for volunteers, which is a very difficult thing anymore to find volunteers, would I have commitment? Anybody willing?
I don't know what you're asking for, Terry.
I'm looking to try and build people who would be supportive in providing education for the advanced care planning, for spreading this news. So it's not all on the back of just a couple of people, but that we have a supportive team and moving forward. Maybe I'm not defining it well.
Yeah, I think it might be great if you could provide a communication to the general membership and tell them specifically what you're asking for, what the time frame would be required, what you're looking for, because I think that right now it's so open-ended that
It's too general
to make that kind of commitment.
Okay. So anybody else have anything to say?
Yeah, I think that we need to be granular about what our projects are going to be. If it's going to be, we're going to go here and we're going to speak about this, and we're going to talk to, what's the audience, where's the location, who's available at that date. We get that granular, I think that people will jump in.
So let me state my concern. We've just had a great conversation about advanced care planning, the need to have conversations with our families, our loved ones, to push that, but also to educate those who are in healthcare. And as Lauren said, her staff, the staff at Livingston, don't always understand and don't remember how to do this education. That's why I'm hoping we can move forward. How do we do that? Is it something that we, as some groups are doing, they're providing education online, they're providing it to certain organizations to be part of that. such I think of the LGBT plus aging coalition. I'm thinking of dementia friendly Ventura County, so that we're promoting education in those areas. How do we do that with the Ventura County Coalition for Compassionate Care, so that Nurse Org understands, so that more attorneys know about this, so that more home health and hospice agencies are involved. That's where I would like to go with this. Maybe that's still too general. So
I say we throw ideas on a whiteboard and see if it sticks. You know, maybe what we do is we create an email string for the whole community and just say, hey, this is what we want to do. Let's start throwing some ideas, and we could
Right.
kind of continue this work through email communication. I think that doing webinars. I think what we do in the hospital is I'll do like a lecture, and then it'll be recorded, and then it'll be required reviewing by everyone who didn't show up at the lecture, and then they just sign off, said I saw it. It's one way to effectively get everyone engaged and to teach and to let everyone know in an organization how important it is to a required viewing or something like that might be one way to go about it. If we can get commitment from all the entities in Ventura County to view something and to say that's our call to action, watch this 15-minute, podcast or webinar or whatever. It could be something we make or something that's already out there, that's already done. That might be a simple call to action. Like, oh yeah, I could get a list of people that signed, hey, I watched this. That's one thought.
Okay.
I think, every member of our general membership has a unique role and a unique perspective and a unique audience. So if every member could think about, well, in the next 6 to 12 months, this is what I think would serve my community that I work with, and say, well, I want to reach 50 people in my community or in my target audience, or 100 people. Just sort of think about a realistic target for yourself and your entity and a realistic time frame. And then let's say, okay, in 12 months, let's look back. How many people did we all touch in our own separate ways? And okay, that's our benchmark. Now, how do we reassess that benchmark and maybe reset it?
Mm-hmm.
Okay. That's very helpful. So something, and also let me put the offer out there. I'm forever putting this offer out there. But if you're very interested in this conversation that we have had and moving forward and helping with planning the education and promotion of education and events, please feel free to join us at the steering committee on this coming Tuesday. To all those present, I will remember to send out the steering committee invitation so that you feel welcome to attend. So thank you so much. Any other comments?
Do
Great
we know when?
conversation.
Right.
What'd you say, Andrea?
I said, great conversation.
It was an amazing conversation, and I'm really glad everybody attended. And for the closing comments, thank you so much, and plan to see you soon, maybe even on this coming Tuesday. Thanks.
Thank you.